Menopause hormonal therapy, or what used to be called HRT, has had a long and complicated history. Its use was deeply impacted by the WHI study of 2002 and the long-standing lack of science investigating women's bodies and women's health. But for some reason, menopause is now center stage. Times are definitely changing with more and more focus on the perimenopause and menopause transition in clinical settings, varied publications of many, many sorts, and the creation of telehealth companies focusing particularly on this time in women's lives. So, are you thinking about hormone therapy? Are you thinking you're too old or you're too young? Are you thinking, what's all this hoopla about the midlife? Why is everyone talking about it? So I want to address these questions. And with the help of my guest today, I want you to leave this episode with a better understanding of hormonal therapy, alternatives, and why this time in our lives can be so impactful, kind of in all aspects of our day to day. I want you to think about a strategy. How do I age with grace and health, understanding what is known in the here and now and what we just continue to learn about? Because again, I feel we're kind of at the beginning if you really think about how deep the science is now going versus where it was at. So we're on the journey altogether. So welcome to Gyno Curious. Your host, Dr. Amy Novatt, from both sides of the speculum. We are here to investigate what it means to be a healer and to be healed. Please thank you for following the show, leaving comments and stars on whatever app you are listening. Today, I am so happy to welcome back to the show Dr. Liz Lyster. Dr. Liz is an OB-GYN who is a dedicated midlife health expert whose blogs, books, and clinical practice demonstrate a commitment to enhancing women's overall health, well-being through all the hormonal shifts. Hi, Liz. Welcome, welcome.
Hi, thank you. Fantastic to be able to spend time with you again.
I know, I know. I'm kind of loving that about podcasts is that I get to see people from across the country who aren't patients, who I'm developing a rapport with. It's very, very nice. Yeah. So let's just dive right in. Hormones have been around for quite a while, despite my intro of saying we're at this new place. They've been around since actually the 1960s. But in terms of kind of the level of investigation around them, the depth and money being put through R&D is certainly changing. But the WHI study in 2002 really shifted the way women were talking about HRT, the way doctors were using HRT. In my training, everybody went on HRT. There was no conversation about whether you did or you didn't. And then in 2002, things really shifted. Can you just
Yeah.
remind the audience kind of what went down in 2002?
Yeah, absolutely. The WHI was a study with many tens of thousands of women that began publishing its data in 2002. It released a press release before they even published so that doctors could look at what they were talking about. And all the important conclusions that they came to have luckily been debunked since then. However, an entire generation of doctors and women have lived under what I refer to as the dark shadow of the WHI. The what we now I like to skip to what we now know. Did you want me to
Go
say a
for it.
little more about the
No,
actual study? Okay.
no, I just do, but there are some listeners out there that are my age, and I just think it's so important to look at history before we kind of look forward or even talk about the present. And what's
Yeah.
so remarkable, I remember the day when the New York Times, Time Magazine, this is when all paper press was still out,
Yeah.
every single publication had a cover story that was, in major, huge font saying HRT is bad. It was perilous. It was an absolute no-no. So literally, women were going off HRT cold turkey, and it was the
Yes.
worst possible thing we could have done for our patients. Yeah.
Exactly. I was trying to sell a house at the time, and my realtor walks in, and she's beet red and she's dripping sweat, and she can barely make it over to my couch, where she like slumps down on the couch. And I knew exactly what had happened. I mean, I
Right.
went ahead and asked her, but I already knew it was
Right.
right in those early moments. And so I like to skip to basically they used the wrong women, the wrong hormones, and the wrong route of administration of those hormones. Those are the three wrongs that added up to way more wrongs that were done to women over the last 20 plus years.
Yeah, so let's go there.
Yeah. And I like to skip to what we now know, and then we can talk
Hmm.
about what they did in the study that was
No, I'm
different
sorry. I
from,
meant let's go to the place
yeah,
now where what do we
yeah,
know?
yeah,
What do we
yeah,
know? Yeah.
absolutely. Okay. So one thing we know is that let's start with bioidentical progesterone. Women's ovaries make progesterone. They don't make progestin. Progestin, and there are many progestins, I know as you know, so for our listeners to know, and that is what was used in that study. And there was actually data that I had learned about before in animal studies. And so that was really not that surprising to me. But we now know that the women in the study there were two very large arms of the study. The arm that was stopped, that led to all the awful headlines, was women who were given horse estrogen. We'll talk about that in a second. And they were given a non bioidentical progestin.
And what do you mean by bioidentical? Can you break that down, please?
Yeah, absolutely. I know doctors especially often get a little prickly about that term. I think it really was used initially in a more marketing kind of way, but I just use it as exactly what it sounds like, bioidentical. The same or almost exactly the same as what the human female body makes. In this case, since we're talking about women and what our ovaries make. So, as I said, our ovaries don't make progestin, they make progesterone. So, we now know there are subsequent large studies using progesterone. And luckily, it's very easy to tell because the prescription bottle says progesterone. It doesn't say
Right.
norethindrone or all these other kind of words that you wouldn't know what they're talking about. If it says progesterone, you're getting a bioidentical progesterone, and that does not increase the risk of breast cancer. The other thing we found out is that also these women were given a horse estrogen, an estrogen that women's ovaries definitely do not make. It's made by pregnant mares, pregnant female horses, and was used for this study. What was interesting and came out, I want to say 2004 or 5, they finally published data where there was the other arm of the study, women who'd had hysterectomies. They were not given the progestin. They were given either the placebo sugar pill or the still not a great estrogen, an oral horse-derived estrogen. But in that arm of the study, the women given the estrogen had a lower risk of breast cancer, which is just like, I mean, that just barely made a blip on the radar because the bad conclusions that were released previously were already accepted as gospel all across. So that was really terrible. So we now know, so number one, bioidentical progesterone. The second is regarding the estrogen, that was an oral estrogen. And what we now know is that estrogen is best used through the skin, or at least non-orally. So that's all kinds of choices, gels, creams, patches, also hormone pellets, which I do like. I do use that in my practice and I use them myself. Anything as long as it's not going through the mouth and doing that first pass stimulating effect in the liver where it's stimulating the production of clotting factors. So a lot of data showing that as well. So bioidentical progesterone, non-oral estrogen. And last but not least was actually sort of a category. This is under we just talked about wrong hormones studied and wrong route of administration, and the wrong women were studied. So if you're in a study and you're having hormone menopause symptoms, you're having hot flashes, you're having night sweats, you're going to know which arm of the study you're in. Were you given the hormones or were you given a sugar pill? So they waited until women were mostly in their 60s, well into menopause. Lot happens. We now know this. A lot of bone density is lost by this time. A lot of inflammation sets in. And so we now know that it's not only safe, but probably ideal to start replenishing hormones really as early as possible, as early as indicated for each individual woman, but really the sooner the better as we're
So,
transitioning into menopause.
yeah, so which is a great segue because I want to talk about hormone therapy and chronic disease. And the Women's Health Initiative, the initial, if you will, purpose of the study was to begin to say, does menopause hormone therapy have any impact on chronic disease, like heart disease,
Yep.
cancers,
Yes.
um, and not only do they take care and bones, not only do they take care of symptoms, but how will they affect these conditions that we know women often die from? And that was kind of the first of its. I think no, I guess in 1988 there was a decision to use HRT for bone health, but then I guess shortly thereafter, when the Women's Health Initiative study was started, which was started in 98 and then came out in
Yes.
2002,
Yeah.
was again, the purpose was to figure out, does this help women in the long run, not just get rid of symptoms, but get rid of these risks?
Yes.
So now, what do we know about hormones and breast cancer, hormones and heart disease, hormones and dementia? Because these are the biggies that women will often come into the office and say, I got to understand this better. What would you say to them?
I would elaborate on what we were just talking about, the oral estrogen and how it goes into the stomach and then to the liver for the first pass effect and stimulating the formation of clotting factors. Because in the WHI, the women did have an increased risk of cardiovascular related issues. Like you said, that's why it was such a huge study between the National Institute of Health and the drug company that made the hormones that were used.
Mm-hmm.
And so there they are finding increased risk of peripheral blood clots, heart attacks, stroke, that type of thing, anything related to clotting. And so we now know we have a lot of data. So for heart disease, estrogen in particular promotes good blood flow, good formation of blood supply all over the body, the skin, the vagina, the brain, all right. And of course the bones. That's so important from a quality of life standpoint. So we do see one of the reasons women their increased incidence of heart disease is delayed is because of our hormones.
Because of all that rich estrogen we have when we're in our reproductive life. That is
Yes.
protective. Yep.
Yes.
Yeah.
Exactly. And so it's associated with, and ironically, the WHI did show a decrease in colon cancer by a
Mm-hmm.
third,
Mm-hmm.
huge decrease. And it also showed better survival. The women who were diagnosed in that estrogen progestin group that developed breast cancer, they actually had better survival than the women who were not on any hormones of all
Yes.
causes, including breast cancer.
Yeah.
Okay, so we do know that. Let's see. Oh, also, it was the first thing to definitively show. So we knew before that, as you were just mentioning, that estrogen improves bone density. The WHI was the first study to confirm that, in fact, that also leads to fewer fractures,
Right.
right? So
Right.
that was a little bit ironic that they were finally able to show that. So that's my own view on that. Is that the improved vascularization all over the body is going to help with heart disease. It's going to help with dementia. It's gonna lower risks of all of those.
I just want to I always remind myself on a personal level, but also my patients, I wish there were a perfect decision for all these questions. There are no perfect decisions. One, because each of us have a different body. Each of us tolerate medications differently. Each of us have a different family history. I've had women, use a little dab of estrogen cream on their body and say, oh my gosh, I get these major headaches. Another person says, I could use 5 times that much and feel like it doesn't affect anything.
Right.
So when we talk about hormones, it's such an interestingly rich conversation, but it's challenging because people listening to us are like, wait a second, tell me how it's going to work for me, for me. And I think,
Right.
listen, I think we'd agree that you have to try to know. So you
Yeah.
started to talk about how, because we know about these protective effects, that maybe we should be starting some of this hormone therapy earlier than we used to. So again, the WHI study, pardon me, started women in their 60s. Most of us go through this menopausal transition, some of us in our 40s, early
Yep.
50s. If 51 and a half is kind of the average age of the last menstrual period in this country.
Yep.
So I guess is it too, when is it too young to start? When might be it too old? How do we answer those questions?
All right, that's a few questions. So let's
I
tackle
know.
that. Let's tackle that. The first hormone to decline as we get older is progesterone. And
Hmm.
that leads to headaches and anxiety and joint pain and all kinds of things, sleep disruption that doctors often give what I call Band-Aid medications, right? Sleeping pills, um, antidepressants, that type of thing, versus looking at the underlying cause. So, a lot of women, when they're not fully transitioned into menopause, so that I went into menopause when I was 43. So, I'm right in that group that you were just talking about, really quite young for that whole process.
Yeah.
So, we can replenish progesterone usually before women need any estrogen.
So
Two,
estrogen levels are still pretty cool. They're fine. It's the progesterone levels are beginning to drop.
yes, they're okay, but they're fluctuating.
Yes.
Right?
Yes.
Not quite as reliable. So we see that FSH test going up and down, and the ovaries initially they respond. So the brain releases more follicle stimulating hormone, and the ovaries like, okay, okay, I'll do it. And then a lot of women will get too much estrogen compared to the progesterone. So they get this phrase that is again a lot of doctors might not be too delighted by, but it's a very commonly used phrase now, which is estrogen dominance, not really there in our medical literature, but it speaks to patients. It reflects what's happening is that there's too much estrogen or not enough progesterone, and that imbalance leads to what you were talking about and
Right.
what we're just saying. So progesterone can, I mean, I love progesterone. Progesterone can help teenagers who are going through the bumpy ride of the ovaries going into a regular rhythm. And now we're on the bumpy ride of the ovaries coming out of a regular rhythm, not ovulating reliably. And also, I had boys, I didn't have girls, but I had my kids in my 30s. So there's like menopause and puberty in the same house. That's really common now.
It certainly
Okay.
is.
Yeah. So,
So
yeah. So,
you're mentioning progesterone. Do people take progesterone orally? Is it different from estrogen?
okay. So that's a wonderful question. Transdermal progesterone is a very easy way to start. There are over-the-counter strength of creams. They're very low strength. They have about 20 milligrams per gram of cream, and a gram of cream is about a half a teaspoon or so. Depends on the product, but they tell you how much. But the dose is going to be super low. The concentration is low. But it's easy to get your hands on. It has been for a long time through just walk into pharmacies and Whole Foods and go online and that sort of thing. But what I do like about it, and I often start with transdermal cream, is that it's easy to start with a tiny amount and work up on the dose. Again, if a woman's transitioning and things are up and down, then she can control and monitor how she's feeling. So I often will start with transdermal. Oral estrogen metabolizes a little bit differently. It gives a little more production of those metabolic products that are even more calming on the brain. So if I'm working on sleep with women, I will often start with oral progesterone, which doesn't seem to have that same stimulating effect in the liver. So they tend
That's
to
what
get the
science would support.
benefits. Yeah.
Yeah, it's so interesting. I mean, there are options for the micronized progesterone, non-oral, but oral is the way many of us give it.
Yeah.
Yeah,
Yeah, it
interesting.
can be used vaginally. Vaginal
Hmm.
suppositories made by a company pharmacy. The vagina is a fabulous route of administration for all sorts of different medicines. So I mean, there are options. Another comment to toss in is that I think you and I were trained the same way, is that women who've had hysterectomies don't need any progesterone, and they are typically not given any. Now, it's true, they don't need it to protect, so the estrogen stimulates the lining of the uterus, and a progesterone balances that so it doesn't get overdeveloped and cause abnormal bleeding or develop into any kind of pre-cancer of the endometrial lining. However, women who've had hysterectomies often have these other issues. And so a lot of times progesterone will be really, really helpful. And it can even help the things that estrogen is more known for, like the hot flashes and the night sweats and all those other challenges that we want to make sure we address.
It's what's interesting to me, and I don't know if it's been your clinical experience. So there's often this, as you've just described, this overlap between what estrogen does and takes care of and what progesterone does and take care of. And there's often a very fine line. And again, it comes down to the individual, where I might take someone who's having sleep issues, give them oral progesterone, and oh, life is just so much better. And then I give
Yeah.
the, kind of same dose to somebody else, same set of symptoms, and they're like, no, it's just not working. And I kind of nudge up their estrogen, and they're like, life is good now. So
Yep,
can I really explain
exactly.
it? I can't, but it's these individual differences, which
That's right.
kind of brings me to audience, everyone listening to us. These are just general guidelines. I want you to walk away from listening to Liz and I today and say, oh, okay, I'm hearing that hormone therapy actually is quite safe. That hormone therapy has a value in protecting my bones, my heart. If I don't take it orally, I might have a reduced risk of that blood clots may not be an issue. That there are some real protective effects here, and that I might even think about doing it when my periods are beginning to get wonky, when I begin to get symptoms, but I'm still only 42, that these are the times, the triggers to start talking to your clinician. Who would you say, is there anyone out there who you said cannot use menopausal therapy?
Okay, that's an excellent question that I have received before. And I am personally very hard pressed to say that there's a category of women who definitely would not be candidates. For example, there is good data in women who've had breast cancer and are then given some type of hormone replenishment. They do great. They have better outcomes. They have lower incidence of recurrence of the cancer, longer survival. And of course, the reason they're usually being given the hormones is because they're getting great symptom relief. They had breast cancer on the young side. So this is, and then what I say for myself personally, my mom had breast cancer at right on the average age of 68, and she's now 86, and she's dealing with other sequela of being taken off of her estrogen right now, with recurring bladder problems, and so she's actually letting me help her with this. So
How does that feel? How
it's
does it feel to have your
good.
mom as a patient?
It's good. It's good. It's been a long time coming. I've let her do her thing. She's a retired doctor, so
Oh, okay.
she will go and do as she sees fit. However, now she's really struggling. So I'm very fingers crossed. So I have a few breast cancer survivors in my practice, and we use at least, for example, a vaginal estrogen tablet. It's going to help the vagina. It's going to help the bladder, right? It's helping the elasticity of those tissues, going to help the pH, help avoid all sorts of other symptoms that are just really irritating. Doesn't help the bones and the other benefits that we were just talking about, but it could really help quality of life. Then we've got women with a family history of breast cancer. They're often extremely concerned. And I really reassure them, especially if they're symptomatic. All right. A woman who's not sleeping well is really increasing her risk, her health risks quite a bit. And she doesn't have to. She does not have to suffer. She doesn't have to struggle. That leaves a lot of other women who really are mostly just going to benefit. And the pendulum is swinging back. I had a patient recently who said, she's in her late 50s, so I've been working with her with her hormones for almost a decade. and doing the bioidentical hormones from when she needed them all the way until now. And she said, yeah, my gynecologist was saying, yes, we now know that hormones are really good for you. And so my patient said to me, I really feel vindicated. And I also feel a little annoyed. It
Yeah, it's a
was
duality that
it's like a
I
big, big
think
delay.
yeah, that many people feel. You know,
Yeah.
the American College of OB-GYN, the National Association of Menopause Practitioners, will talk about how hormone therapy is not appropriate for a woman who has significant gallbladder disease, a significant history of clots, breast cancer, any estrogen-related cancers. These are the biggies. But
Yeah.
I think what you're pointing out, Liz, is that again, that part of what we should be doing as clinicians and patients is trying to figure out not just quantity of life as best as we can or promoting quantity of life, but promoting quality of life. And as you pointed out, if somebody is struggling so much with her menopausal symptoms,
Yeah.
guess what? Those are risk factors too. Chronic sleep deprivation, we know. Chronic stress, we know. I'm so tired I can't exercise, so my bones are getting more and more brittle. We know these are real risk factors.
Yeah.
So Liz and I can't say for sure that there aren't risks associated. We can only say your job is to bring your questions and write them down. When you go see your clinician, you write things down before you enter that office because you can get very distracted by the pace of the visit, the nurse coming in and knocking on the door, all kinds of distractions. Have your questions and know that yeah, there are people across this country, across the globe who might have slightly different opinions about estrogen and progesterone, for example, in a woman who's had a history of breast cancer. I mean, as I pointed on Gyno Curious before, I mean, I've interviewed a breast specialist, a local breast specialist, who is adamantly against any estrogen. I mean, any estrogen, vaginally or otherwise. And I said to her, you know, I get your perspective. You know, you're looking through this
Right.
periscope of you're constantly seeing breast cancer and in young
Right.
women, seeing women die. That hurts and that's hard to see every day. On the other hand, you come to my office and you hear all about the complaints of vaginal dryness, vaginal irritation, the genital urinary syndrome of the menopause, and how women are giving up any kind of sexual contact, intimacy because their vagina hurts. Hear
Right.
that day in and day out, and you want to help. You
Yeah.
want to help. I'm not
Yeah.
saying being deaf, dumb, and blind to the risks. I'm just saying, all right, I'm going to try to look at both sides of the speculum and understand what might be the safest route from the from the start and reevaluating. When we make decisions as clinicians, right, Liz, we're not saying, oh, this is the way it's going to be forever. No, we're
That's
seeing
right.
patients
That's absolutely
again,
right.
yeah, and trying to figure out what might work.
Yeah.
And
That's so great. Hmm.
yeah, which brings me to like, okay, so this question about why is everyone talking about the midlife? I know that you've recently had a real shift in your life, that you very kindly shared with me when we last spoke. Do you want to tell us what happened?
Yes, well, it was just a few months ago that my husband, very unexpectedly, he was just having some very diffuse sort of stomach bothering him, just not feeling great. And finally, he got the correct CT study done and was found to have very advanced pancreatic cancer. And he died 9 weeks to the day after that CT scan. And it was just a terrible ride. I mean, I don't know about you, but I went into OB-GYN because I love taking care of mostly healthy women. I'd never seen anything like that. My parents have both been through cancer. They're both doing great. I just had no experience seeing someone that ill. It was really, it was awful. It was awful.
Mm,
It was terrible. It was as terrible as anyone might imagine that it was.
yeah.
I'm only just at a point where I can even say anything about it. But it was really, really difficult. I was grateful for, I met him when I was 51. We got married a
Mm,
year later, and he was in his 60s. He was 9 years older than me. And so we really tackled all kinds of the health issues that one goes through when you're in those decades. We really tackled them head on, and really, really, the time that we got was very, very special. So,
Well, I'm so grateful you're sharing it with me and the audience, and I'm impressed that you are keeping it together because I know that it would be it's such a profound loss.
yeah,
And I also know that so many of my friends and colleagues and patients during this midlife, this time where not only our bodies are changing, but our worlds are changing. And whether it's the loss of a partner, the shifting in jobs, all of a sudden our children are grown-ups and they've left the house and all of a sudden their problems are, they're not
well, they're
smaller, they're
back
bigger.
and
And
they
yeah,
bounce back. So, yeah,
that's right. That's right. And so when
yeah,
I had actually, it's funny, I was just talking to a woman the other day who said to me, I don't know what she used the words. I don't know what the hoopla all about is. Like I'm no longer having periods. I think she was just kind of 2 years post last menstrual period.
yeah.
So she was early in her menopausal experience. She's like, I don't know what everyone's talking about. I'm like, well, I'm glad that you're comfortable and I'm really glad that life is stable for you right now. Um, and we talked about the biology and the mechanics of the menopause and just bone health and all these other things. And then I don't know, there was this recognition, and she went on to talk about how she'd been a writer. She is a writer, and how she had just realized that after many, many attempts to write a book, that it may not happen in this life. And it was a
Mm,
major um, realization.
yeah,
She wasn't
yeah,
sure what to do with. She
mm,
didn't know what to do with it.
yeah,
She didn't know if she was going to continue to write or not, or change what she wrote. But it was profound, and I hear this over and over and over again.
yeah.
So, I guess, what would you say to our listeners around grief and this midsection of our lives and the opportunities associated with it? It's a big question.
I
So,
would,
yeah.
one thing I would definitely, this is personal sharing from me, and what I talk about with my patients is the phrase stress
Oh,
tolerance, replenishing hormones. And we haven't touched at all. We could have a whole nother conversation another time, Amy, about testosterone for women.
oh, yeah.
All right,
Yeah.
especially for this breast cancer specialist that you have near you. There's one that I refer people to her website all the time because she's a breast cancer surgeon. She treats breast cancer with testosterone.
You want to
It's
mention her name
very
just so people
interesting.
have it?
Yes, she is Dr. Rebecca Glaser, Glaser. Okay, and
Okay.
so she has a whole lot to say about that. Lots of studies, hundreds of studies on her website that are posted in one of the sections on there. And I started replenishing hormones from the minute I had my first hot flash. I was 43. I was still doing office gynecology. I had samples in my cupboard. I recognized that it was a hot flash. I said, right, go get that little patch. And I felt better very quickly. And I've just, in these last many years, I've tried all the different forms, patches and gels and creams and that sort of thing, and also testosterone, which at the moment women cannot get from a regular pharmacy. It has to be from a compounding pharmacy. And all of it helps with being able to stay clear, stay focused, get enough good sleep, motivation. There's no way I could have made it through what I went through with Michael if I didn't have my hormones in good shape.
Mm,
I really strongly believe that. I've
mm-hmm.
been into it with things in good shape, and made sure that that was part of my self-care. Make sure I was sleeping, make sure I was able to think,
Mm-hmm.
and manage what I needed to do for myself, in order
Yeah.
to, put your own oxygen mask on first so that you can then be there for the people that you care about.
Yeah.
I would like to toss in a comment that I really hope that this person you talk to, she could write the book. I really encourage women, but sometimes we need, so hormones can be helpful with that, like really, with the brain sharpness, the focus. So there's a lot of support. So whenever women have those kinds of dreams and goals, I really try to be a bit of a cheerleader. One more thing I wanted to remember to say that you made me think of is something I say to women all the time, which I think is very important for our listeners also, is that using hormones, replenishing hormones in order to feel better does not commit you to using them forever.
Please
A
unpack
lot
that
of
for us.
a
Yeah.
lot of women think that. They think I'll just get through it and then I'll be fine because then I won't have to be on hormones forever. And it's just not the case. Women can, they don't have to suffer and struggle through the symptoms and the lack of sleep and the lack of sex drive and the lack of metabolic results with all the things that we're doing, right, for our try to manage our weight and keep strong muscles and keep good bones and all of that. So using replenishing hormones, for example, progesterone to help you sleep, estrogen to get rid of the night sweats and the hot flashes, all of it to help with mood stability, etc., doesn't mean you'll have to use them forever. So that's, I think, often helps women feel at ease because they go, okay, I don't have to struggle through. I can use what the hormones to replenish and feel better now, and then we over time we can taper down.
Yeah. I want to just a question that often comes, and we're getting to a close, and this is maybe starting a conversation about something that deserves more time, but we talked a bit about hormones and bones and the value of bones. A question that I hear over and over and over again is why are we waiting until 65, which is when
Absolutely.
the bone density is being recommended? Why aren't you recommending the bone density earlier? Can you speak to that?
Yeah, absolutely. I am encouraging my women, at least when they turn 50, wherever they're at, if they're still having their menstrual period or they're in menopause or transitioning to menopause, is ask your primary care doctor or your gynecologist for a baseline bone density scan. You are 100% correct. The U.S. Preventive Service Task Force recommendation of age 65 is crazy. That's way missing the boat. Way, way, way missing the boat. And it's so important. A hip fracture has a way higher mortality and morbidity than even breast cancer
Yeah.
and many other illnesses. So it's so, so important. So I encourage women, I mean, at this point, we just have to be the tail that wags the dog and ask for what we need. I love what you said about bring your questions, write them down. Another thing that I add to that is ask the questions right at the beginning.
That's a great,
Don't even let the
great,
doctor get started
right.
because you don't know how long she has.
Right.
She might not have as many minutes as you were expecting, or she could get called out or something like that. So at least you give the questions to the doctor. I like people to give me the whole list because then I can make sure we touch on the whole list as we go through our time together.
Right. Right. Great. Great. There's a word that I've heard you use, which is reinvention, and it's not unique to you, but it sounds like what we're in a way metaphorically talking about today is the reinvention of our journey into the perimenopause and menopause through hormone therapy. And we didn't touch on alternatives, but no, to those listening, there are alternatives to hormones if you absolutely can't tolerate them, don't want to use them. There are medicines for bones, there are medicines for vaginas, there are medicines for flushes. So again, ask those questions or ask about them. But we're talking also about reinventing ourselves with the events in our lives. And Liz has, shared with us so graciously about the loss of her partner. And we all face loss of one
Yeah.
form or another. And so the question is, how do we remain resilient? How do we remain strong? And when our body is feeling healthy, I don't know about you, Liz, but when I'm feeling healthy, emotionally, I feel like I can take care of things. I
Yeah.
can
Yeah.
move through things. But when I'm feeling ill, um, I had the flu last week, for example. I couldn't deal with anything. I was kind
Okay.
of physically
Yeah.
just stuck to the sofa. But
Yep.
even emotionally, I had a phone call from a kid who was asking me to help them figure out some quandary they were in. And I'm like, I really can't think about it right now. I just want to sleep. I just want to curl up. And
Yeah.
I think I'm not sure I don't think that's unique. I think when we're not feeling well, we can't expand
Yeah.
our hearts and our minds to the world around us.
I agree. I wholeheartedly agree.
Yeah. Yeah. Liz, thank you, thank you, thank you. And I just wish you health and healing and again space to remember Michael with great memories
Thank you.
and reinvention. Yeah,
Yes.
reinvention. Yeah,
Transformation and reinvention. Absolutely.
yeah. Be well.
Thank you.
And thanks to Matt Mercier, who's here with me today in the studio, who's making this happen, and to the co-producers, Maddie Rosenberg and Jen Hammoud. Stay well out there, please. There's a lot going on in the world. So do all that you can to take deep breaths, listen to your instincts and intuitions. They're the greatest of teachers. Stay well.